Welcome to the Cancer Support Suffolk podcast. Join me, Mark Murphy, and my brilliant guests as we talk about life before, during and after cancer. Hello, I'm Mark Murphy, the CEO of Cancer Support Suffolk, and welcome to our latest podcast, supported by the Suffolk Community Foundation and the Suffolk and North East Essex Integrated Care Board. Every month we'll be talking to people who've had a cancer diagnosis and they'll be sharing their personal stories with us. We'll also be talking to health professionals for all the latest news on the treatment of cancer. Well, this month we're looking at breast cancer. With me are Henie and Janet, who've both been diagnosed with breast cancer. Hello, welcome to the show. Good to see you both. Thank you very much for joining us on the programme today. And we're also with Mr. Hussein Tuffaha, who is consultant Oncoplastic and Cosmetic breast surgeon at Ipswich and Colchester hospitals based in Ipswich. Thank you also very much for joining us.
Good morning.
On the podcast today. It's really good to see you all. Janet, can I start with you first of all? When did you first realise that something was not right?
So it was in March 2022. I'm very aware of breast cancer because my mum died of cancer at 69, breast cancer. And my sister, who's younger than me, was also diagnosed with breast cancer about 2 or 3 years earlier than me, though she's younger. So anyway, everything was fine. I do check myself regularly, but strangely, when I actually found the lump, it was lying down. I hadn't felt it when I did my normal checks. I was laid down in bed and I was a bit achy, and I thought to myself, oh, I'll just check again. And it was right underneath. So I didn't actually feel it standing up. And it was when I did that and I thought, hang on, what is that? It feels like a lump. I didn't tell Simon, my husband, and straight away the next day I booked for a mammogram.
So that was a shock then, lying down to feel that.
Yeah, absolutely. Especially because I do regularly check myself. So that's one thing I would say to your listeners is do that as well, especially lie down and feel it. Because when you're smaller, you're not a bigger person, there's all kinds of lumps and bumps anyway, which are your ribs and muscles. So make sure, not only when you're standing in the shower, which we get told, when you can, do it while you're lying down and get used to how you feel normally, if that makes sense. Before, I actually went for my ultrasound and saw yourself. And I think you more or less, in your own words, were saying to me, I think it's cancer. So I had prepared myself. The only thing that was a shock was when I got the diagnosis. It was, because I was expecting it, if I'm honest, it was the rarest form. So it's metaplastic, which is only 1 to 5% of women in the whole world get it. Rarest, most aggressive, straight away, you've got to have a mastectomy. And then it rolled on from there.
So once you were in the system, my goodness me, it moved very quickly.
It does move quickly, very quickly. And I have to say I was very impressed with the service that I've received, not just with regards to the mastectomy and the follow-on. I had a few problems with the mastectomy afterwards. Straight away, I would go into the hospital as soon as I rung up. Yep, come in, let's have a look at it. But also the chemotherapy that I had afterwards was brilliant. I have a friend who volunteers in the John Levere, which is the Cancer Support Centre. So she kind of directed me to go there and get help. So I have to say I have had a brilliant service.
Hennie, what about you? When did you first realise that something was not quite right?
It was about 2 weeks before Christmas 2021. And like Janet, we've got a family history. I was the 5th case in my family. So my aunt has always nagged me to check myself. So 2 weeks before Christmas, I checked myself. And it's actually the 3rd time I found a lump. The first 2 had obviously been nothing. I think one was a lymph node and one was a cyst. And this one just felt different to the others. So I knew instantly that it wasn't right. So I went and told my husband. And as Janet says, you book an appointment. Given the family history, I was seen quite quickly, although there was a delay. So I wasn't actually seen until January. So I had the whole time over Christmas knowing that there was something that wasn't quite right. But what are you supposed to do? You just get on with it. So I went back in and the first doctor or the first nurse sort of looked at me and she said, I think it's probably just a cyst, but we'll do an ultrasound just in case. And they did the ultrasound and went, we think you need a mammogram. So I had the mammogram and then they said, we think you need a biopsy. So I said to the lady that was doing my biopsy, I said, look, realistically, come on, what are we looking at here? Do I need to be worrying? Do I, what? And she said, well, I can't really say, it's not really my place. I said, I can't do the next 2 weeks of the not knowing. I've already had a month of not knowing. I just want to know. Because the not knowing, I think, is worse than...
Yeah, it is.
She sort of said, I think to be honest, you probably need to prepare yourself for some bad news. Okay, that's fine. My husband did not want to prepare himself for bad news. He's very much, life's going to be nice and shiny, and we're going to not worry about it until we need to worry about it. So I think the day that we sat with a very lovely Irish doctor who told us it wasn't such good news, it was more of a shock for my husband than it was for me. And I can remember in that moment, I sat there and I took a deep breath and I thought, how I deal with this moment will govern how I deal with the next year, 2 years. So I took a deep breath and I said, right, what are we going to do about it? And the doctor kind of looked at me and he said, sorry? And I said, well, what are we going to do? There's no point me sitting here being upset. I just need to know what we're going to do going forward. I need a plan. And obviously for me, given my age, there was discussions about fertility and whether we wanted to freeze eggs. We already have a daughter, so it was whether we wanted to expand our family. I felt that I would rather be here and present for her, and I didn't want to delay my treatment. So we just sort of said, no, there's not even an option right now. We need to make sure I'm still here. And then I started with chemotherapy. Then I had a single mastectomy. Then I had, which I had to have second surgery for because it needed some correcting. And then I had radiotherapy. And then last year I had a mastectomy on the other side as a preventative. So I've had 4 breast surgeries in the last 2 years.
Gosh.
Yes.
Janet, you're kind of nodding away there, empathising.
Yeah,
with Henny's
it
story.
resonates with me, especially with Simon, my husband. He found he was in denial most of the time. When I'd seen you, I knew it must be. So I'd kind of got myself prepared. You prepare yourself because of your family history and everything else. But he was in denial. You're all right, Janet, because I've never really been an ill person. I don't drink a lot. I don't carry a lot of weight, so I've never really been ill. So he was in real denial. So he found it harder than I did, in a strange way. But you're right, I think the waiting for results, even now when I have scans, I get really nervous going up. I have to have 6 monthly scans because of the type of cancer it is. I get really nervous getting up to it and stressed. And 2 weeks after, I'm waiting for the results. Then you're sitting waiting in the hospital to get the results and you feel sick and all of that. But I've come to the conclusion you've just got to get on with life. You've got what comes. You can't do anything about it. You can eat healthily. You can do all the things. I don't drink alcohol anymore because that increases your factors. I've looked at type of foods I can eat. That's all I can do and try and keep myself healthy. What will come will come. I mean, I had a problem with my mastectomy in that it became swollen. In essence, the fluid that has to be released got stuck. And they basically had to push it out of me. I didn't have a second mastectomy because they said, unless you've got the genetic link, it's not worth it because it is a, especially at my age, I'm nearly 60, it's a major operation that you don't actually need if it's not genetic.
So
Hussein, can I bring you in there?
Here about the second mastectomy because this is a very important point. A second mastectomy has no benefit in most people with breast cancer. Only people that either have a known genetic defect that we see or been assessed to have a very high chance of developing a second cancer would benefit from a mastectomy of the other side. But in most people, we wouldn't recommend the mastectomy on the other side. And also, another important point on mastectomies is that mastectomies are not better than lumpectomies. So if you can avoid the mastectomy, it's better because the first thing. One of the first instincts in people, and you can correct me if I'm wrong, is when they know when a woman knows that she has breast cancer, she's like, just take my breast off. And actually, this is not the best operation for you unless you actually absolutely need it. So a lumpectomy is better than a mastectomy. It's better in terms of survival. It's better in terms of body image issues. It's better in terms of complications. So what I would like to bring across is that don't jump into mastectomies. If you can, have other operations to save your breast.
And that's what I struggled with at first because I had to have a mastectomy. And luckily for me, the surgeon that did my mastectomy said that if it's where she thinks it is, which was right in the middle of my breast and it isn't linked to any more tissue or my skin, they'll do a conserving. So my actually skin and nipple was conserved. And I actually call it a scoopectomy because basically they took everything from inside. I was reconstructed straight away, so I didn't go through that struggle.
That's exactly what I had as well.
Yeah, and it's a strange thing because you then don't have to have the struggle of be flat-chested. But the first thing I wanted, get the other one off. And I would like to ask a question of yourself. So a colleague of mine also was diagnosed with breast cancer 6 months after me, and I supported her. She had triple negative. She got her genetic test straight away. I basically had to struggle and fight to get the genetic test, having a family history of it. Though it must be that when I did it, they must be different to mine. I don't know what my mum or my sister had. They would never tell me. Though it took me a lot of like fighting on myself with Cambridge to get the genetic test. Luckily for me, I haven't got the genes problem, and now they check for 9 genes rather than just 3. So that was brilliant, because by the time I did my friend had hers in December and she was only checked for 3. And this is a thing about how things increase and get better in time. And by the time I had mine in the January, having been diagnosed in the March, it was 9 they were checking for, and I was clear of all.
So with genetic testing, we have criteria that we would assess. So there's 2 sets of criteria that we do, one at diagnosis and one after treatment. And these are based on evidence of the current evidence that we know. So, and these are for what we call mainstreaming. So if we have somebody who's younger than 60 years old, for example, with a triple negative cancer, what we do at the moment is at diagnosis, we actually counsel them for having genetic testing, and we send the blood tests. But with the specifics of your case, obviously you have been sent to Cambridge, and then they did their analysis based on what they know. So I'm not an expert in this area, but we have a set of criteria that is available to us in clinic, and if you satisfy that criteria, we immediately send you for genetic testing initiated by us. Mm-hmm. However, if we say, for example, you don't satisfy that criteria, like in your case, you're metaplastic cancer, so you don't satisfy that criteria from that point of view, but we think, you've had 2 relatives that have breast cancer, you have a very unusual cancer, we will send you to Cambridge, and then they will do their analysis and decide when to do the testing. And obviously they have decided to do the testing on you.
Yeah.
But yes, so we do follow a criteria that we do, yeah.
Yeah.
It's very interesting because just between the two of you, you've talked about the different types of breast cancer. There are so many different positions a lump could be.
Of course.
So treatments are very different for lots of different people?
Yes. So there's a lot of types of breast cancer, and there's a lot of outcomes and pathways that people need to go through. So when I speak to people about their cancer diagnosis or before their cancer diagnosis, so when I saw you and told, I prefer to be honest with people. So I prefer to say, listen, this looks like cancer. Based on what I know from your imaging or whatever, this looks like it's amenable to treatment. Don't worry about it. There's nothing you can do. We just need to see you in a week's time, and we'll discuss the results. And then when we discuss the results, we'll have a little bit more information. So we'll have information about the type of cancer. So it could be ductal from the milk ducts, could be lobular. You need to test it for whether it feeds on estrogen, whether it feeds on progesterone, whether it has a receptor called Herceptin, which is amenable to certain targeted treatments. It's very complicated. But based on these information, then we can tell you whether you'd benefit from surgery or whether you'd benefit from having chemotherapy first, for example. And there are reasons for that. And if you are benefiting from surgery, we would aim to preserve your breast if we can. If we can't, then we would want to do a mastectomy. And if we do a mastectomy, we would aim for someone to go to sleep with a breast and to wake up with a breast if possible. So a reconstruction. And that could be immediate or delayed, depending on what you want. But we would offer reconstructions to suitable patients, and that could be your own tissue, like having a tummy tuck and having it put in, or having an implant. And again, there's suitability. There's, if you're young and you don't want to have to be off for 3 months and you want to be mobile, you can have an implant first, and then later on you can change your mind and have the bigger operation, etc. And then you just go down that journey. And I think this journey is, as it's happening, is very fast, and you're surrounded by people. You're just going to appointments all the time. You feel that you're just like more or less just embraced in a way, and you can confirm this. If you don't.
I absolutely agree. I actually think though, like Janet was saying, I think it's harder for those around you because you're at the eye of the storm. You get, like you say, all the attention, all the information, everybody around you making sure you're okay. And I actually think it was harder for my husband because he didn't have that support, people checking on him. He wasn't involved in those conversations necessarily. He might have been in the room, but obviously it was about what I wanted to do because it was my body. And he really struggled with why they weren't doing surgery first because his gut reaction was, get it out, get it out. And the doctor was saying, well, no, actually, for this specific type of cancer, because it also spread into my lymph nodes, we need to put chemotherapy in and kill it before it can spread. Because also while I'm recovering from surgery, it's got a chance to spread elsewhere. So that was, from my understanding anyway, that was their reasoning for me going that way around. And he really struggled that I had to sit there with this thing inside me.
It's probably because we only have a basic grasp of what for you is a speciality. And I've always been of the opinion, well, if I had a cancer diagnosis, it would be just as you said, get it out, get it out. But we need to listen to the people who know how to deal with this. And treatments have come on tremendously, haven't they, in recent years?
There's lots of advancements. There's targeted therapies, there's immunotherapies, there's things, triple negative breast cancers, for example, and HER2 positive breast cancers. The reason why we give them chemotherapy first, obviously, other than to treat them quickly and to sterilize their body from any hidden cells, is because a lot of them respond to chemo. More than half of them respond to chemo, and the tumor completely melts away. And if you take that tumor out, you wouldn't know the response. But if you give them the treatment and it completely disappears, then that's fine. But if it doesn't, then you need to give them more treatments and things like that. And also it shrinks the tumor. It sometimes enables you to avoid mastectomies. There's lots of benefits for that. So sometimes what I would say is that as a layperson, as a person who doesn't deal with this and doesn't understand the underlying science and complexities, sometimes your instinct and what your body tells you that you need to do is not the right thing. And when we make decisions, obviously we do empathize with you, but we also think about this in an objective manner, and we're trying to do what is best for you rather than what you feel is best for you. Does that make sense? And I think it's a very important role for a consultant. We have this debate a lot of times, is that I'm not here to have a discussion and then do exactly what you want to do. I'm here to tell you what the evidence is for your case and to guide you to what I think is best for you. And then for us to reach a shared decision on how we proceed.
And I think that works really well because for me, it felt more like it was personal to me because strangely...
And increasingly it is though, isn't it?
It is. It's like to a point, it's like a personal service because, for example, my metaplastic, and I've learned a lot about, obviously, and I'm sure you have, about breast cancer. Metaplastic breast cancer is usually triple negative. Unusually, mine isn't. I do have some sensitivity to estrogen. So obviously that changed my treatment plan because I was given and I'm on letrozole. So I've called that my insurance policy in a sense that kind of helps to keep it away. I get confused about why I'm only 5 years and my sister's 10 years and things like that, but I think that's to do with age and
again,
menopause.
this is about not everything works exactly for everybody because this is about risk stratifying people. So when we basically look at your risk profile and look at your cancer and everything else and the lymph nodes and your age. And based on that, again, based on evidence, statistical evidence, we calculate something called a risk, a recurrence risk. And depending on that, we give you 5 or 10 years. Because in some people, giving the letrozole, which is a hormone-blocking tablet, or something similar, like tamoxifen, which people know more, is not beneficial for you beyond a certain amount of time. And the only thing you risk after that is the risks of it. Like with tamoxifen, there's a risk of endometrial cancer. With letrozole, there's osteoporosis and problems with your bones and things like that. So you need to balance that risk and benefit profile.
Well, I actually found that out because I said, why aren't I on 10 to Dr. Sherwin? And she explained it is on a matrix. Yeah. And because you're on I can have 5, but I could go to 7.5 if I don't have any, because you do get side effects from the tablets, don't you? And if you cope well with the side effects, she said, we could maybe do 7 years if you could coping well. But if you're not coping well, and I've coped well, the only really thing I've suffered, and I'd like to know what you, is I do get hot flushes still, but it's then where I can just chuck my covers off. It comes and it goes. So it's really easy to cope with. Just get cool again, bang, and a little bit of achy bones. But I'm taking the horriblest tablets in the world, the calcium D tablets, which are horrible. They make me every time. But I've started to take them every other day because actually when I did start taking them, I overdosed on them in essence. I got calcium in my blood, which is a sign of blood cancer. So I'm like, oh God. But it wasn't. It was actually I must have enough in my diet. So I've cut it down. But So you do get side effects. So when you've had the breast cancer, you've had the chemotherapy, I think people out there don't realise it does continue for 5 years. I've got to go in for the infusion to help my bones. I'm coming up to my last one in January. So it continues beyond your chemotherapy.
Yeah, I mean, my doctor said to me, once you finish active treatment, you're still in cancer treatment until the end of thing. And I kind of thought, well, I don't feel like I am. I feel like I've kind of got my life back. I have to take a tablet every day. It's not a lot of fun having hot flashes, not being able to sleep, gaining weight. Cold flashes, that's always fun too. So I have, but then also the side effects I've had with tamoxifen have not been as bad as other people I've known. So as much as I do get the side effects, if having a couple of hot flashes in the day means that I get to still be here, then that's a trade I'm happy to make. Yeah. I haven't had a full night's sleep in years now because the tamoxifen obviously has done something to my sleep. But again, you just learn to adjust. And if waking up at 3 o'clock every morning and 2 o'clock every morning and 5 o'clock every morning means I get to still be here and watch my child grow up, then that's a fair trade.
Absolutely.
Yes.
This just shows how everybody is different, aren't they? It really does.
Yeah, and that's a very important thing. We moved away from the paternalistic type of you just do what we tell you, and we really believe in individualizing care and also shared decision making. Those are really important principles of how we try to work.
Yeah, you're coming up with the expert's opinion. It's got to work for you as well. But so many different treatments now compared to before. And more, I would imagine, on the horizon as well.
Well, strangely, so I was diagnosed in March. My friend was diagnosed in the December. And by the time, so I went through my treatment, the immunotherapy had come in. So she was given immunotherapy. And if, hopefully, touch wood, it doesn't come back, if it did, or when it did, I will be given immunotherapy. So things are always just moving on. I find it a bit difficult that there's not a lot of research on metaplastic, but that's because of its rarity. But the research and the changes, and there's been 2 changes in the 6 to 8 months that I was there.
And there are other than the treatments, other than the immunotherapy, other than all of these medications that we can targeted treatments for cancer. There's more individualization, like gene panels that you do. It's not genetic testing, that's different, but it's in certain people that are suitable. You can actually test the cancer itself to assess whether somebody would benefit from chemotherapy. For example, there's a test called Oncotype DX that we use in certain people with estrogen receptor positive cases, node negative, and sometimes 1 or 2 nodes or whatever. But traditionally, these people would be recommended to have chemotherapy, but we actually do the testing, and that testing says this person is not going to benefit from chemotherapy. So you avoid giving the chemotherapy for this person. And chemotherapy it's not an easy experience. Obviously, both of you had chemo, and you can talk about it, but it's something that we would like to avoid, and these tests help us, for example, avoid chemotherapy if people don't need it. And I think there's also advancement in terms of the surgery that we make. So, a lot of people used to have mastectomies, for example, in the past, historically, and there are places still that half of the patients would have mastectomies, but we've developed oncoplastic techniques where we combine the plastic surgery with the breast surgery, where we can do things like make the breast smaller. Sometimes silver linings for people with big breasts. They develop a cancer and say, I will give you 20-year-old breasts now, and just give them a breast reduction and a lift and whatever, and do it through that and things like that. So there's developments surgically, and there's developments from the therapeutic agents.
Yeah. It was interesting, Henie, you talked about the weight, waiting,
Yeah.
which none of us like for anything. We don't, we particularly if it's, something like cancer, we want to know straight away. But hearing Hussein talk there about all the various different tests and things, you can perhaps now see why it takes a week or so to come up with the right results for you and the right plan going forward.
You
worry that nothing's happening, don't you?
Yeah, the logic part of your head knows it's because you need the right information. It's no good giving you a half answer the next day or anything like that. You want all the information, but I'm someone that's very information driven, which means having no information is much harder for me than being overloaded with it.
So from my perspective, I would just say something to this. I find it very difficult to tell somebody that they have cancer if they haven't been prepared. So if they saw somebody else and that person said, oh, we don't know what it is, we'll find out next week, it's much more difficult for me to break the news because the person in front of you will be hit like a rabbit in the headlights, because most people are hopeful and say, no, it's going to be nothing, it's going to be nothing. Whereas if I say to someone, listen, it looks like it might be cancer, you can't do anything about it, it looks like it's treatable, we'll discuss it next week. When they come, they've already had a week to prepare for that reality to become reality. It's still difficult, and I still made it real on that day when I tell them that they have cancer. But it just makes it much easier to move on the conversation, rather than somebody just literally slapped in the face saying you have cancer, and then somebody coming at you with information that you're not hearing, you're not paying attention, you're thinking about everything else in your life, and it just makes it much more difficult.
At the time, it seemed hard when you said that to me, but you're right. When it came to actually getting the full diagnosis, I was ready for it and dealt with it.
You've had
better.
a chance to process what might happen.
Yeah, all you're thinking about, you're thinking, well, it's going to happen.
Forewarned is forearmed.
Yeah, it's forewarned is forearmed, and that really helped. And even in my treatment, I didn't have radiotherapy because that wasn't going to benefit me with the type of cancer I had. So I only had chemotherapy. So it shows how it's individualised.
You're both looking after yourselves now. Important to look after ourselves anyway, isn't it? Because you mentioned chemotherapy is pretty tough. Some of the treatments are pretty tough. The healthier we are, the fitter we are, the more chance our bodies have got of dealing with these treatments than if we're not looking after ourselves. So it's important for all of us, wherever we are in our life, to really try and be healthy and look after ourselves so that we're strong to go through anything.
And exercise is really good exercise and looking after yourself is really good with helping you cope with the chemotherapy. So yes, you try to be as healthy as you can, try to be as active as you can. And there are people that work through it, so they would have chemotherapy and still go to work and things like that. I think it's a mindset thing. Obviously, different people have different mindsets. I don't want to be judgmental and say, you don't have the right mindset to deal with it, whatever. But I find, from my experience, the more positive you are, or the more factual you are, for example, like you, I can deal with this, or it is what it is. I'm just going to have to move on and just have to take it one day at a time, one step at a time. It will help you cope with it, rather than trying to think about the consequences of things and it's going to happen. I'm going to die or whatever it is. Your outlook really affects how you manage your treatment, and if you just either be positive or focus on the next step and not think beyond that, it does help.
Yeah, I agree.
I did exactly both those things. And actually, I mean, when I was diagnosed, as I say, we had a 7-year-old daughter, and she became the priority because it's a lot for a child to have to deal with. And we were advised to obviously be open with her, to be honest with her, because we didn't want her to feel like we were lying to her about something, because then once I was better, she may feel like she'd been betrayed in some way. And I thought, this thing's taking enough from me. I'm not having it damage my relationship with my child. So we made a very focused effort where the deal was that I would focus on getting better and my relationship with her. That was my priority. And my husband, God bless him, did everything else. So he was working full-time, he was doing all the housework, he was doing all the cooking, he was picking up all the slack that's normally done as a partnership. And it meant that I got to really make sure that I was there and I was present, she was included. And I can remember when I was diagnosed, we had people saying to us, you can't tell her. You can't tell her because that's going to be too much for her to deal with. And I thought, well, she's going to know because I'm going to lose my hair. I think she's not stupid. She'll know. And I think it's kind of probably quite old, not an old thinking, but it's sort of a more traditional thinking maybe, that children should be protected. They shouldn't be involved. They shouldn't be included. And to us, I've always been raised, it's important to communicate. It's important to talk about things. And this was a really good opportunity. So it means she's been forced to grow up a little bit. She's had to, face the fact that her mummy may not have survived. I knew I was going to, but it's still always a possibility, isn't it?
Yeah, we do encourage that parents speak to their children about it. And there are resources, and there are books and stories and things like that, support to actually help families navigate this with the younger children.
I found it helpful to just get it out there. So I had a son in university. I had to tell him over the phone because I thought, if I tell him to come home, he's going to worry about it. Just get it out there. And then you've got to move on. You've got to be positive. I use humour a lot of the time. I've gone bald. I've got no hair. Brilliant. I don't need to buy razors. All them kind of things just to take me through it. And I stay positive now, and I do use humour. And for me, my friends and work were a salvation towards the end. I stayed off during chemotherapy because it was end of the pandemic. So the risk of, but I would meet people outside. And then as soon as I could get back to work, I did, because it was my salvation.
Let me just ask you about that, because a lot of people struggle when it comes to knowing what to say to you when you go back to work or you talk to friends. They kind of skirt around, well, how are you, and all this kind of stuff. What's your experience of that? What would you like to hear from, when you go into work and things like that? Just,
I think, I don't know about yourself, but I think you do find out who your real friends are.
Yeah, definitely.
There's ones that really, like you say, do not know what to say, and they'll just ignore it. All you want, for me personally, was that first time they meet you, how are you, I'm thinking of you. If all you get is a text saying, I'm thinking of you, and they don't do it again, that's fine, because life goes on. You've got to live your normal lives as well. It's like when people say, oh, leave work and go and do all the things you want to. Well, yes, but you've still also got to have a normal life. We've got my boys at home, husband. You've got to do the normal things and the nice things you like. And for me, being back at work, and though people were asking, because I was still bald, obviously, because I think I went back more or less about 2 months after the chemotherapy, just part-time, I was doing work. I was not... It was Janet, the police officer, retired police officer. It wasn't Janet, the cancer victim. It was, I'm getting on my own, I'm doing my work. So that was a salvation for me.
Henie, what about you?
So when I was first diagnosed, I've got a group of friends, we're all quite close, and I just put a thing on the group chat saying, this is the situation. What I need from you is nothing. I need a salvation. I need somewhere that I can go where it's just normal. I don't need to be constantly asked, how are you? Are you okay? I need somewhere that I'm not going to be reminded I'm ill, that I just want the conversation to continue as normal. And if I'm struggling, if I need to talk, I will. But they gave me the safe place of just normality. So, if I had a moment where it was all getting a bit much, or I had lots of decisions to make, I could go on my group chat and they'd all be complaining about their kids drawing on the walls, or, and it just gave me a release and escape. And I had another friend who was amazing, and she made me T-shirts for every single chemotherapy. They were all stupid ones. So I had one that got me into trouble. It said, it had a 1-star review saying cancer would not recommend. And I went out for lunch with a different friend, and this man came up to me and he said, I'd like to say that I find your T-shirt very offensive. I said, I'm very sorry. What? Why? Would you recommend cancer? And he said, well, no, I've got it. And I said, well, so do I. And I think humour's the way to deal with it. For me, personally, I wanted to be surrounded by joy and positivity. I don't want to be asked constantly how I am. Like you say, it's nice that people touch base, but I didn't need a constant thing. And I'm very good. If I needed to talk, then I would talk to somebody. And
there is support out there. For instance, at Cancer Support Suffolk, we offer counselling sessions in this very room that we're sitting in now, and complementary therapies at the hospital. All of those kind of things are available. There's lots of help and support. But it's interesting, you both talked about partners, because what we've seen actually since I've been at the charity in the last year is that we're working with more partners, because they sometimes, particularly the men, find it really difficult. They're meant to be, the traditional style of breadwinner and all this kind of stuff, and they find it quite difficult. So we've been working with a lot of partners about this, and many a time you'd be sitting in the room and the woman would be stone-faced, ready to get on with it, and her partner is just basically breaking down next to her. You can see it. It's very obvious, and it's reflective of how roles have changed in terms of people are partners, and everybody's more expressive, if you will, and you do see it a lot. And on a negative note, you see sometimes relationships break down with a cancer diagnosis because the partner cannot deal with it, and they just
I was
run
actually
away.
warned about this. It's one of the appointments that I had. They said to me, there is a chance that your marriage will fail because of this. And I sort of looked at her and I said, well, it won't. I know my husband, and I know that we'll get through this and it will all be fine. And she said, well, we do find that it's better to just forewarn women that apparently there's a higher chance of men leaving women when they're ill than there is of women leaving men when they're ill. And I thought, that's horrifying, isn't it?
I didn't know that. I didn't know that.
Yeah. But that shows why you need the counselling and the support services around it as well, not just for the cancer patient, but also for the partners as well.
I know Emma Simon has this happen. He still does it now. He'll say, what do you want to do? And I'll say, no, what do we want to do? It's not all about me. We're in this together. Well, what about that? No, what do we want to do? Because it's a partnership, and you've got to get through it together. as a family.
One final bit of advice for people listening today about early diagnosis and screening. Can I start with you, Hussein?
Of course,
What would you say?
First of all, the most important thing, even more important than mammograms or attending screening regularly, is to check yourself. So the best way is to examine yourself, choose a time of the month, first Friday of each month or whatever it is. Examine yourself, sit it up, and also examine yourself lying down, because sometimes you can feel stuff either lying down or sitting up, which you can't feel in the other position. There's lots of informative videos on YouTube that you can see on how to examine yourself. You know, a lot of people come because they have breast pain. Breast pain is not a sign of cancer. You need to look out for a breast lump, a change in the shape of the breast, indrawing, nipple discharge, nipple changes, skin changes, and these things, rather than just breast pain. So that's the most important thing. And the other thing is, don't be afraid to ask for help, and attend your screening mammograms if you are asked to do them. You know, screening is not perfect, but it does help, and you know, it helps us pick up things early. And the earlier we pick it up, the less you will have in terms of treatment.
Don't run away from it.
No, just come. We'll see you. We usually are very good. We see people within a couple of weeks. We give you diagnosis a week after. If you need to start treatment, surgery or chemotherapy, within a few weeks. So we are there, and we provide a good service, especially where in my patch of the of town, if you will. But just come, ask for help, see your GP, and don't be afraid.
Okay. Henie, what would you say?
I'd say, leading on from what Hussein was saying, Copperfield actually do a free text service as a reminder for women to check their breasts. You just sign up and they'll send you a text once a month to check. Like you say, checking is important. Out of all my friends, I was the only one that regularly checked myself.
Really?
Yeah.
And what about now?
Now they all do, thankfully. So I'm hoping that means that, you know, I may have made a difference somewhere.
More people listening to this hopefully will as well.
A couple of friends have found lumps since then, and thankfully it's all been fine. But at the time, I thought, thank God it was me, because at least I'm the one that checks myself, and at least otherwise it wouldn't have been found. Which kind of leads on to my point that actually if you find a lump, whether you do something about it or not, won't change what that lump is. If it is cancer, then finding out gives you options to have treatment. If you do nothing, it's not going to make it magically not be cancer anymore. It's still going to be cancer. There's just nothing or less that can be done. So I kind of feel like, why wouldn't you go to the doctor? Why wouldn't you go and get it checked? Because you might just get a better outcome.
Yeah, speedy treatment, or it might be nothing anyway.
Yeah.
So, and then you have the relief, don't you?
And I would add to that is that we have treated cancers. We have treated ladies who are 28 years old, 27-year-old with cancers. But I would caveat that with one thing, is that if you're a younger lady, I would say under 35 years of age, it's unlikely to be a cancer. So what I would say is that if you do develop a lump, just wait until after your next period, see if it goes away or not. And if it doesn't, then seek advice. And that doesn't mean delay. It just means that you wait for 2 or 3 weeks just to make sure that it hasn't gone. So you don't need to panic if you find something, but just wait for a couple of weeks, see if it goes away or if it persists. If it's cancer, it's not going to go away. Or if it's something that needs to be investigated, basically. And then we will see you. We will see you quickly, within a couple of weeks of you going to see your GP. So, yeah, I would just say that.
Okay, Janet?
Likewise, I think it's more about, when you find that and you're sure about it, go and get it looked at. Because I think, for me, that saved my life. Because I had an inkling, then felt it, and because of its seriousness, it hadn't spread. So it's kind of saved my life. And my mum ignored it. And my mum died of breast cancer because she ignored it.
Yeah, don't bury your head in sand.
No.
Just go and get it checked. We hear that so often, don't we? So often that early diagnosis is so important. Look, thank you very much for joining us on our latest podcast. It's been lovely to talk to you, and thank you for all of your contributions, for being so honest, the pair of you two, as well. I know it's not easy to talk about issues like this, but thank you very much. And Mr. Hussein, thank you very much for joining us particularly as well, and best wishes to you and everybody at Esneft. Thanks for listening to this episode. If you'd like more information about what we do, then head to cancersportsuffolk.co.uk. You can call us on 01473 211 884. We're based in central Ipswich in Suffolk. Cancer Support Suffolk is passionate about educating and supporting the people of Suffolk, and as a registered charity we rely on donations and fundraising to be able to continue our vital work in the community. This podcast is the copyright of Cancer Support Suffolk and is produced and managed by podtalk.co.uk, supported by the Suffolk Community Foundation and the Suffolk and North East Essex Integrated Care Board. Until next month, from all of us at Cancer Support Suffolk, goodbye.